Good afternoon and welcome to the Long COVID and Post-Infectious Syndrome Echo Series, brought to you by the University of Utah and Bateman Horne Center. If you're new here, we're glad to have you, and if you're returning, welcome back. I'm Talia Raschioni, the Education Director and Deputy Executive Director at BHC, and I co-host these sessions with Sarah Day, Echo Manager at the University of Utah. Before we begin, just a couple quick housekeeping reminders. This session is being recorded, but all of the attendee and case discussion will be removed before we post it on our websites and YouTube channels. After the session, Sarah will email CME instructions and the slide deck. CME must be claimed by midnight tonight using the call-in option. It may take up to 24 hours for that to appear on your profile, so check back tomorrow if you're not seeing it right away. Please feel free to introduce yourselves in the chat and engage to your comfort level. Today's presentation is a little different. It was pre-recorded because our speaker, Dr. Clayton Powers, is actually on vacation, but he's so dedicated to being with us today that he is here and he will be interacting with you in the chat box. This session really is geared towards bringing us back to the fundamentals of patient care. Clayton will take us through the practical principles and tools that we all can use in our day-to-day clinical practice to help us improve patient outcomes. We would really love to make this session as interactive as possible, so please don't hesitate to use the chat box to share your insights, your questions, and your ideas. Okay, let's get started.
Thank you for this opportunity. I'm super excited to share this message. I'm Clayton Powers. I'm a physical therapist at the University of Utah, specializing in helping individuals with complex health conditions, including long COVID and ME/CFS. And I hope to be able to follow up on the fantastic presentations by Dr. Kahn and Jamie Booz about navigating medical uncertainty and improving patient visits and patient communication. And I hope to focus on care in patient care in order to improve outcomes. We're going to go back to the basics of care. Nothing to disclose or no conflicts of interest, and all the patient examples in this video or presentation, the individuals have given consent to be recorded and to have their perspectives shared. Here are the learning outcomes. First, I want to start with a story. When my wife was going into labor with our second son, I remember that we got in the car, her water broke in the middle of the night, and so we had to rush to the hospital, and we were driving there. We show up at the parking lot, and when we navigated to the front desk to try to find where we should be, the individual at the front desk said, "Are you okay?" in a tone that was very much like, is this normal? My wife, what she heard was, "You're not normal. This level of discomfort is not normal for somebody who's going through labor and delivery process right now." So that's what she heard, even though the individual was trying to offer help. When she said, "Are you okay?" that tone really made us lose confidence in the ability of that provider or that place to really help. And so I want to talk about how our communication with patients and the setup of our patient visits can influence patient outcomes. And I use this picture because oftentimes when you walk through hospitals, they seem scary for a lot of people. They're hard to navigate. They can be bright with bright fluorescent lights, shiny floors, and all these hallways. And so when we went through that process of my wife going into labor with our son, it's a stressful process. On the other hand, for our third son, when we went through this process, we had an amazing midwife who was just fantastic at recognizing my wife's needs intuitively. There was a time where my wife was sitting and meditating, and me and the midwife were having a conversation. And I remember the midwife stopping our conversation as she glanced over at my wife and said, "Is our conversation bothering you?" In which my wife said, "Yes." And so she said, "Okay, sorry, we need to stop talking so she can focus." It was probably more my fault than the midwife's fault that we were talking, because I was having a conversation with her and I'm kind of chatty. So that showed this higher level of understanding and care from this midwife, that she could sense what my wife needed without coming out and expressing those needs explicitly. So if you don't have the basics of care in place, then your treatments will not be as effective. So what do you consider the basics of care for someone with long COVID or ME/CFS? And please, throughout this presentation, I hope that you fill up the chat with your thoughts. Please share your opinions and have a discussion on the side, sharing what you think throughout, because I'm going to have a lot of questions like this. So if we want to improve patient care, we want to aim for this ideal in care. First, we have to describe or build a picture of what that ideal looks like. And then we can work backwards to put in place the steps that we need so that we can reach that ideal. So in the book, 7 Habits of Highly Effective People, this is called having your end in mind. So creating this mental image. So I want you to think of, at your clinical practice, what is your end in mind? What's the ideal clinic setting for your patients with long COVID? And then throughout this presentation, I invite you to take notes of what you're going to do to work backwards from that ideal and make changes so that your clinical setting improves for these patients. So in order of priority, what outcomes matter most to your patient? You can put this in the chat or in your notes, but in your opinion, what outcomes matter most to your patient? And also, what outcomes matter most to you as a provider? And then lastly, what outcomes matter most to your organization? I think if we put the patient first, then we as providers are going to have more job satisfaction, less burnout, more fulfillment, and our organizations will also benefit. That's why I put the patient outcomes first, but please share what you think are most important. Here are just some examples of outcomes that we may aim for, like improving quality of life for the patient, improving understanding and support from family, caregivers, or also for disability purposes, getting financial support or other social accommodations or support can be really powerful. And this can lead to a clinician having more fulfillment with helping these individuals. And this ultimately, if we do a good job, can reduce healthcare utilization and reduce unhelpful or wasteful patient appointments and visits. So I want to share an example of what this might look like sometimes in the clinic if we're trying to aim for the ideal. What was your experience like during your first PT appointment?
Yeah, so I remember it really clearly because it was different than any appointment that I'd ever had with any doctor with any illness, not just with long COVID. I came into your office and I sat down in a chair and I was wearing a mask and you saw that and you put on a mask right away and then you dimmed the lights. Like as I was coming in, you dimmed the lights. And I sat in the chair and you said, "Are you tired? Would you like to lay down?" And I was like, "No, I'm fine." And I stayed in the seat and we were talking and I remember like just that, like how difficult it can be to talk when I'm feeling exhausted. And you said, "You seem really tired. Are you sure you don't want to lay down?" And then I was like, "Yeah, actually I do." And I laid down and you brought in this like leg compression thing and some ice packs, and you were like, "We can just let's do some things to help you feel better before we continue with taking history and gathering this information." And I remember the experience feeling some relief in that moment, of the relief that I now know comes when I am more horizontal, when my feet are up. But at that point, I didn't know that about long COVID. And so I had this in the moment experiential learning of a strategy that could help me feel better. And I didn't have that information before that appointment. And I remember it so vividly because I think most of us are experiential learners on some level. And that appointment, like, it clicked something in my mind that helped me, one, understand that you understood long COVID very clearly and deeply and empathically, that you knew more about it than I did. I knew what it felt like, but you knew some strategies that could help me feel better. It built immediate trust for me with you in terms of feeling like, oh, whoa, this guy knows something that's going to help me and help me feel really bought into the process and invested in the process. And I, I think of other PTs that I have seen during the time that I've struggled with long COVID, and the lights are really bright, and they're, some of their offices have beautiful windows and views, but that bright Montana light can really be challenging and give me headaches. They have me sitting in a chair and they're talking, and sometimes they're talking loud. You clearly modulated your voice to be quieter, which was really helpful for me because sound can be hard. Sound can be hard. Light can be hard. Having my feet below my heart can be hard. And experientially, you immediately brought me into this higher level of knowledge about my illness through that first appointment. And from there, you've helped me build my knowledge and understanding of how to take care of myself with this illness. But that first appointment was critical in building that foundation of trust and a foundation of knowledge about things that I can do at home now. And I do those things at home. But, you taught me that in a way where I knew it was true and I believed it because I felt it. It wasn't just a recommendation that you gave to me verbally. It was a recommendation that you had me experience, and I knew it was helpful. And so I have implemented that at home in terms of cold and compression on my legs and laying down or getting my feet up, decreasing light, using earplugs. All of that came from that first intervention.
So often when patients come in for an appointment, they look at a bed like this that doesn't look comfortable, but they would love to be able to lay down, but they don't know if they have permission to lay down or put their feet up. It's so important that when patients come in for an appointment with long COVID, we first share permission or give permission to lay down or put their feet up, grab a stool so that they can recline and put their feet up. Or often when someone comes in, I immediately say, go ahead and lay down if you want to. And most of the time people will say, no, that's okay. I'll usually insist and say, no, I'm serious. If at any point during this appointment you want to lay down, please lay down to help you tolerate this better. And I would prefer that we had most of our appointments be telehealth. Sometimes that's not possible. And so that option of laying down in the clinic and providing a place to elevate the feet is super important. So from start to finish, the patient experience should be taken into consideration in order to reduce exertion, stress, confusion, fear, and the likelihood that someone will experience PIM because of the appointment. So in every aspect of a patient coming in for an appointment, how can we reduce the level of exertion? And so in the chat, I want you to share what you do or what you think would be the ideal for reducing exertion and stress for patients. And then what is the ideal clinic environment for treating someone with long COVID or ME/CFS? What picture do you create in your head for that ideal? And please share in the chat what you think. And then in your notes, what can you change about the environment you practice in order to improve care for patients? Are there some things are hard to change or you're unable to change at your hospital or clinic, but what could you implement after this presentation to improve care? What are the most vital aspects of an appointment? If you really look at overall what's important when you look at an appointment, there's lots of paperwork and there's documentation and other things that have to be done. But what do you consider the most vital parts of the appointment with a person with long COVID or ME/CFS? And please share what you think. Here are some ideas of some of the most important things, but I want to hear what you have to say as well. So, building a therapeutic relationship, I would put as highly important in that visit. And that goes along with understanding their needs, validating, providing hope, and deciding on a plan with informed consent. Those are all I consider parts of that therapeutic relationship. And then a piece that I see that's often missed is leaving the patient feeling better than you found them. So if a patient comes in for an appointment and is already exhausted from the drive to the appointment, how can you help them feel better than you found them? And I think that goes back to giving permission to lay down, using cold packs or other things that can help with symptoms in the appointment and make it more comfortable, or even just giving rest breaks throughout the appointment, dimming the lights, talking in a lower tone. Because when patients wake up for the appointment, they are waking up often with a lower battery than most other patients, or depending on the day, their battery may be hardly charged at all in their body. And so they have low energy and don't feel well. We want to conserve that energy through the appointment process. So, what can you minimize or remove from your appointments? And this may be better in your own notes. What can you do to save patients energy? And I hope you come up with some ideas for what you can do to change how you go about a patient appointment in order to reduce the amount of energy you take from the patient. In one of the clinics I went to a few years ago, it was really interesting because as I walked in, on the wall, I noticed this sign that said, "In, out." That was easy. Go to the pharmacy. And I thought, maybe for some people that messaging is really helpful because it shows, oh, this is going to be quick and I can get out of here. But for patients with long COVID, that can seem a little bit like the providers or the clinic doesn't actually want to hear their whole story or what they're going through. And so this messaging can also impact patients with long COVID when they go in for an appointment. If they're getting this message, hey, we're not going to take the time to listen, but we'll send you to the pharmacy. And so we want to make sure that our messaging in the clinic and from clinic staff is showing that support and validation, and that we want to hear what you have to say. So here are some other ideas for ways that you can improve the appointment setup and reduce the energy that patients use throughout that process. We also have to think about how, as a clinician, we can prepare ourselves to engage with a patient. So if you're like this provider and you're exhausted and stressed or frustrated and you're having a bad day, then it's going to be hard to bring in positive energy or to really connect and have empathy if you're feeling these types of symptoms. So what can we do as clinicians to prepare ourselves at the end of a long day to be able to provide effective care? And please share in the chat what you think a clinician can do to prepare themselves, or what do you do to prepare yourself? And often, how do you recognize when you're feeling other emotions, stressed, fatigue, or overwhelm? And what do you do to remove those prior to interacting with the patient? And do you have any biases that you have to set aside or that you can recognize in yourself and work on so that you don't bring that into the appointment with the patient? Please also, I'm going to say it again, share in the chat, what characteristics do you think a healthcare provider needs in order to effectively treat someone with long COVID or ME/CFS? And what skills can a provider learn in order to effectively treat someone? So please share with each other. You have great ideas that are much better than what I have to share. So please share with each other what your thoughts are. Here's another patient example though.
I had to go to an emergency care doctor that was not my normal doctor. And she had never heard of long COVID, or she'd heard of it, but she didn't understand. And she literally sat with me and said, I want you to tell me about what's going on with you. How does long COVID look? She was inquisitive. She spent time with me and just didn't just say, I'll treat shingles, off you go. It was like, I need to understand what's going on. And to me, I left that office, I was in tears. It was just like someone's just sat and bothered to listen, which should not be the case with medical care, because it might be medical, but it isn't care. And that's what people with long COVID want. They want care.
That's what people want. They want care. They want you to take the time to ask them questions. And I know I'm speaking to the choir. Most of you are very aware of this as clinicians or people interested in long COVID. So just a reminder that that's what people want, is that sitting down and listening and validating. There was a survey done just this year looking at what the impact of getting a misdiagnosis was, a psychosomatic or psychiatric misdiagnosis, when that person actually had an autoimmune condition. And these misdiagnoses or in your head diagnoses impacted patients' long-term physical health and diminished their trust in healthcare services. It found that over 80% of patients reported getting a misdiagnosis, that it damaged their trust in clinicians. And then it created a long-term distrust in clinicians. When this happens, higher levels of depression and anxiety and lower mental well-being. And it often, these impacts of misdiagnosis can still upset them, often even decades later. And this can create a lower level of satisfaction with medical care, increased distrust in doctors, and then often people will avoid healthcare services because of this gaslighting. We need to bring awareness to this, and I know we have been, but bring awareness to this for other healthcare providers to realize the impact when they say, oh, it seems like it's just anxiety or you're just deconditioned. Because language matters. This is another study that just came out this year. Amy Mooney shared this one with me, and I think it's a fantastic study on effective communication between healthcare providers and how we can improve that so that we can have a positive patient care outcomes. Patients facing difficult medical situations such as life-altering chronic medical conditions feel especially scared, vulnerable, and out of control, which adds a level of intensity and emotional charge to these interactions. In these emotionally charged situations, practitioners may feel de-skilled or revert to more authoritative language and styles of communication, which can then leave patients feeling discounted and unheard, evoking fear and distrust. This is a great picture illustrating this, is that often patients will hear what the study termed as never words that can be really harmful for mental health and can lead to more frustration, stress, and exertion. In this example, I would say the never word would be, oh, all of your tests came back normal. And that can be very frustrating and create more stress. Then what is going on? Is this in my head? And without further context or explanation, this can lead to a long-term impact. So people with long COVID or myalgic encephalomyelitis and other complex chronic disorders consistently report having difficulty obtaining effective and compassionate medical care and being disbelieved, judged, gaslighted, and even dismissed by healthcare professionals. These problematic conversations often involve these never words, which can leave patients in significant emotional distress and negatively impact the clinician-patient relationship and recovery. So here's some of the negative words. In the study, they offer an explanation and the impact, as well as an alternative phrase you could use. So some of the never words include, you don't look sick. You need to stay positive. At least it's not cancer. Learn to live with this. Good news, your tests are all normal. Many people have it worse. Have you tried this? So that advice giving. You feel sick because you have this going on. You need to do this, lose weight or start exercising or get some fresh air. You look too young to be sick. Or we don't have any treatment for your illness. Oh, there's no cure for long COVID. You need to stop thinking about your symptoms so much. You have to find something productive to do with your time. Don't confuse your Google search with my medical degree. So these are just some of the examples of never words, but there are alternative ways to talk to patients that can be more effective at building confidence and reducing stress and helping to give patients hope. So one possible remedy that the study offers is that clinicians should explicitly acknowledge previous misdiagnoses and discuss and empathize with their patients as to the potential ongoing impacts and offer targeted support to reduce the persisting negative impacts. What do you do? Please share in the chat. What do you do in your practice to rebuild trust with patients who have had this experience? If you had to look at what are some of the leading or the most impactful thing in early mortality risk, so risk of premature death, what would you think is the number one most impactful contributor to early mortality? In a big meta-analysis in over 148 studies and 308,000 participants, they found the random effects weighted average effect size indicated a 50% increased likelihood of survival for participants with stronger social relationships. And this finding remained consistent across age, sex, initial health status, cause of death, and follow-up period. So social relationships actually had a bigger impact on the risk of premature death than smoking or exercise or even access to healthcare. So our social relationships are super important, and so are our patient-provider relationships. So why does the therapeutic relationship matter when treating patients with long COVID and ME/CFS? What do you think? Share in the chat why this relationship matters. There is one study showing when a primary care physician-patient relationship is severed, that this can increase patient mortality by 4% and increase emergency department visits and hospital admissions. So our relationships with patients do matter. I'm sure you all know that, but share why you think that matters. Another study looking at chronic pain showed that several studies have shown that social support is associated with less depression, anxiety, and pain-related distress, which I would also put in this case symptom-related distress. So how do we help our patients with their relationships? How does our relationship influence outcomes, but also how can we help our patients with their relationships? Please share what your thoughts are. On one example, I had a patient who was really struggling with long COVID. She was a stay-at-home mother and could hardly function to take care of her children. And her husband would be working all day and would come home and just feel like the house is a mess. You haven't been doing much. It doesn't seem like you're able to care for the kids much. And he was getting frustrated. And she had told me that they were considering divorce because he just couldn't understand it and was getting frustrated with her. And it was really having a worsening impact on her health, but also he just felt like she wasn't pulling her weight, that she was lazy and she just needed to try to exercise more. And so we actually met, we did a telehealth appointment, and I shared different resources and tried to break down what was happening to her body and why she was experiencing these things, and that it's not laziness, deconditioning, or one of those in your head diagnoses. And by the end of the appointment, his tone had changed. When we started the appointment, he said, well, what exercise does she need to be doing to get better? Or what does she need to do? And by the end, he was saying things like, well, what could I do to help? Or what help can we get for her? And I spoke with her a year after that appointment. And she said, no, we're still together. We didn't end up getting divorced. After that appointment, that really helped our relationship, and he was much more supportive. So I think there is a role we can play in helping to maintain or help people with their relationships, and that can have impacts on patient outcomes. Now, I want you to share with each other in the chat, what do you think are the most important elements of building a therapeutic relationship with patients? What are those key pieces that need to happen in order to build that trust? And here are some quotes from research. The doctor-patient relationship involves vulnerability and trust. This study actually broke down 4 key components: knowledge, trust, loyalty, and regard. I think all of us can come up with some ideas for what are the most important pieces for building this relationship with patients. These are some of the key components. At its core, the doctor-patient relationship is a fiduciary relationship by which we enter into a relationship where the physician agrees to respect the patient's autonomy, maintain confidentiality, explain treatment options, obtain informed consent, and provide the highest level of care, and commit not to abandon the patient without giving adequate time to find a new doctor. However, such a contractual definition fails to portray the immense and profound nature of the doctor-patient relationship. Patients sometimes reveal secrets, worries, and fears to physicians that they haven't disclosed to family or friends. So placing trust in a doctor helps them maintain or regain their health and well-being. The US MECFS Clinician Coalition, in their guide for diagnosing and treating MECFS, they say, number 1, validate the patient experience and educate about the disease. The most important thing that a medical provider can do is to validate the illness for the patient and the patient's family, and explain that MECFS is a serious medical illness and is not laziness, depression, or one of those in your head diagnoses like a psychosomatic disorder. Then the next step is address impaired function and provide support. So before we even give medicine or before we provide other treatments, we're providing support. Patients may need help in obtaining accommodations or help with disability or parking permits, assistive devices, home health aides, or other food or shelter. These are the basics of care for these individuals. Just providing support, even if it's not medical or pharmaceutical or something like that, these can often have higher impact because it helps reduce stress and helps the patient use less exertion. And so these are some of the basics of care. As a healthcare provider who has long COVID, what do you wish more healthcare providers understood about patient care?
I think one of the most challenging things as a patient with a chronic illness that doesn't have a clear treatment pathway is coming to a level of acceptance within myself that this is what my life looks like right now, maybe not forever, but for the time being, and that there are things that I can do to eat around the edges in terms of symptom management. But ultimately, I have a chronic illness, and there's a tremendous amount of emotional, mental processing that needs to happen for a patient around that acceptance. And I remember when I first realized that I could not keep on working as a clinician and really fighting against that and thinking, okay, I'm going to take 6 months off and then I'm going to work really hard and get better. And long COVID, like MECFS, is not the kind of illness where if you work really hard, you're going to get better. It's, and it's this sort of opposite thing where I am getting better incrementally. I know that I I can do things now that I couldn't do a year ago, but it's a very slow process. And if the patient can't come to a level of acceptance, I know this as a counselor, there's going to be like tension and turbulence inside. They're going to have relapses where I know I did this, where I pushed myself too hard. I was like, I want to get out there and start exercising again. And then I ended up in a huge crash that lasted months. And I think one of the things I imagine is really hard for healthcare providers is that all of us are in this profession because we want to help people heal and get better. And when you're working with somebody with a chronic illness that's not technically curable, you might get better, but we don't have like a treatment pathway to cure somebody. There's no antibiotic for this. Is that I really appreciate the providers who can come to me with the compassion and understanding and who have worked on that acceptance within themselves. There's a different tone that comes from a clinician that has that level of acceptance than from a clinician who is like really cheerleading or needing for themselves for me to get better.
I think that's super important as well. I've had patients where they've told me that their physical therapist told them, "Oh, you're getting better. Your heart rate is more stable. Keep doing the exercises. It's making a difference." And I've asked them, "Well, how is it making a difference in your life?" And the patient says, "I don't know, but it seems like my physical therapist thinks it's getting better." And so often healthcare providers, we want people to get better. And so we sometimes impose that on them instead of being accepting of where they're at and trying to just support. And so with that patient, I was sharing an example when I actually said, "You know what? How about we do an experiment where you take 3 days off this exercise program and see if it was actually helping, or if you feel better by doing more rest breaks." And she actually took 3 days off the exercise program and came back and said, "Hey, yeah, actually I feel a lot better by not doing the exercises." So I think, sorry, the example I was sharing was not the patient in the video, but a separate patient. So educating about pacing and preventing PIM is a huge part of the intervention or treatment process. So even though there are pharmaceuticals or other treatments for patients with long COVID, some of the basics like educating on pacing and providing support may be more impactful for patient outcomes than some of the medications. We've mentioned this a lot in these echoes, but addressing PIM and screening for PIM in healthcare, because if we miss individuals in the healthcare system who are suffering with post-exertional malaise, it can have health impacts and lead to ineffective, harmful healthcare. So we should be, as healthcare providers, pushing to raise awareness that patients should be screened for post-exertional malaise before appointments. So screening for PIM is part of the therapeutic relationship basics, setting up a healing environment. And that first impression that we make with a patient really drives whether they can trust us. If they get a sense that they can trust us, then that's going to lower stress and exertion. Looking at some of the factors that trigger a physiological stress response. Stress responses are exhausting. If you've ever been in a stressful situation, you know that afterwards you feel more tired. So how can we lower the stress for patients? Please share what your thoughts are. In this study, they looked at what are the components of a physiological stress response, or what triggers a physiological stress response. And they found sense of control, threat, unpredictability, and novelty. So what can you do in your clinic or your practice to improve the patient's sense of control over their symptoms or over their situation, to reduce threat, to reduce unpredictability, and to even reduce novelty with the appointment? So what can you do in your settings? Because stress burns a lot of energy that patients don't have and can increase the likelihood of inflammation and post-exertional malaise as a result. Part of this appointment or patient interaction is reducing that stress and sense of threat. I love what Jamie Booz said, which is the patient shouldn't feel like they're going in for a job interview when they come in for an appointment. It should be a different kind of setup where we're much more empathetic and we lower our tone, we dim the lights, offer permission to lie down. So we want to pay attention to tone, our posture, our facial expressions, and our distance from the patient. I had one patient who, throughout the appointment, I had dimmed the lights, offered her to lay down. I tried to speak to her with a lower tone, more calming, and allowed for rest breaks. At the end of the appointment, she shared with me, she said, I don't usually like to work with male providers because I was sexually assaulted as a child. And she said, but with you, I feel comfortable and safe. And I didn't know when she came in for the appointment that she had that history, but she felt comfortable enough to share that and felt safe. And that's what we want for our patients, is when they come into the appointment, that they feel safe, that their stress and threat level are much lower as they work with us. So making eye contact can be helpful to show that you're acknowledging their concerns instead of staring at the computer, showing curiosity, recognizing signs of post-exertional malaise or discomfort or other fatigue or things when it might be time for taking a rest break, using clear, simple language and being emotionally present. And I love this one, asking for permission to share advice instead of saying, here's what you need to do to manage your symptoms, asking a permission question. And this one is so tricky for healthcare providers. Instead of just giving advice, saying, would you mind if I share some tips that have been helpful for other patients with similar symptoms? This research article looked at physical therapists. When a patient comes in, their pre-treatment expectations may be, oh, the physical therapist is a body expert or an exercise instructor. And then as you build that therapeutic alliance and they have a different experience than their expectations, they leave and their post-treatment experience or expectations are, oh, the physical therapist is an educator and is person-centered instead of just an exercise instructor. A lot of this I learned through motivational interviewing principles applied to care for long COVID, but I learned it in regards to other different conditions. It was originally developed to address abuse disorders, but it can be helpful for a wide range of therapeutic interventions. And some of these principles involve active listening skills like avoiding judging or correcting the patient or arguing with the patient, focusing on their concerns, listening and not interrupting, providing feedback and information with permission. And then some of the nonverbal communication I talked about, which is your posture, your gestures, your facial expressions, and then making it more of a discussion-based situation instead of that temptation to lecture the patient. What matters most to patients are these key factors, and I want to hit on professionalism, the attentiveness, communication, demeanor, being truthful and respecting patient preferences, and being patient with the patient. Mayo Clinic did a study in 2018, and they found that physicians interrupted their patients within 11 seconds on average. That shouldn't be the case. It doesn't take that long for patients to share what their main concerns are. Clinicians seldom, they found in the study that they seldom elicit the patient's agenda. When they do, they interrupt the patient sooner than previously reported. Physicians in specialty care elicited the patient's agenda less often compared to physicians in primary care. Failure to elicit the patient's agenda reduced the chance that clinicians will orient the priorities of a clinical encounter toward the specific aspects that matter to each patient. So we want to use these open-ended questions. Here are some examples for you. I have a lot of different examples of questions that can be asked that are more open-ended. And then affirmations. So saying things like, I want to thank you for coming into the appointment today. I know that it takes a lot of energy to come in and this is a sacrifice. So thank you for coming today. How often do people thank their patients for coming in to meet with them? And then also other words like your input is important, your experience is normal. And then using reflective listening skills to try to show that you have been listening by reflecting back. It sounds like you, or you want this, is that right? And that gets into the summaries to reinforce what's been said and show that you're listening. You want to ask questions like, here's what I've heard. Tell me if I'm missing anything, or did I miss anything? What have I left out? Let me see if I understand so far, so that you can really try to orient to the patient's needs and what they're hoping to get out of the appointment. Moving forward, as you take some of these tips, or as you take your notes and what other people shared in the chat, and try to reach that ideal or that end in mind, give yourself some grace, because none of us are perfect. I know I've made plenty of mistakes and continue to make mistakes, but as long as we're trying to work backwards and improve and move toward that ideal, that's what patients want. Despite our best efforts, some patients will still experience post-exertional malaise as a result of the appointment or visit. But if we can do our best to minimize the threat and stress and try to create a healing clinic environment for patients, that's what should be the best. That should be what we aim for. What changes are you going to implement to reduce stress and exertion during appointments since this presentation? And now we'll open it up to questions or comments. I hope that this was helpful, and I hope that you can take away something that you can change so that we can better improve patient care and really show that we care. Thank you.
Clayton, I loved that presentation. For the group here, I know that you're probably thinking, okay, I'm trying to join these to get back to some of the pathology and practical things that I can be using with our patients. But the mentor team and planners for this have really wanted to use the first few sessions of this series this year to go back to those basics, because it's that will make the biggest impact on all of the other interventions that you use with your patients. And so that's really why we structured these first 4 sessions in this way. We will start to tip back over into more of the pathophysiology and real practical application of those clinical skills in our next one next month, and then as we continue through this series. But I just wanted to take a moment to kind of explain our reasoning behind that, and really, thank you, Clayton, for bringing us back to some of those fundamental basics. If you haven't had time to look at the chat, there's been a lot of really good discussion. I love a lot of the suggestions in here. It's almost like we need to take what's been put in the chat box and make that into a simple, one pager that we just kind of keep on all of our walls and as a quick reminder. And I think it's also really empowering for our patients too, to be met with providers who see them in this way.
One of the comments that I really loved is that all the staff have to be trained to be able to recognize this. Everyone who interacts with the patients, from the front door staff to people making the phone calls, everyone has to be trained on recognizing the need for empathy and compassion toward this patient population and reducing stress. I know we've had some staff at our clinic who have said, oh, they missed their appointment, we're going to send them a notice that their other appointments will be canceled. And I go, whoa. Like, let me tell you about what kind of struggles, not sharing HIPAA, but let me share what kind of struggles this patient population has with being consistent with appointments. And often, once we educate the staff on those concerns, and hey, don't make them fill out paperwork at the front, they're already exhausted. Can you bring them back quickly to a room and let them lie down somewhere? Those little tips and training for additional staff can be really powerful to make the whole healthcare environment better for those patients. Because in general, the healthcare system is not great at creating places like waiting rooms where a patient can lie down in the dark and in a quiet area. They make them bright with fluorescent lights and lots of people, and it's not conducive to healing for this patient population.
Really good points. I mean, it starts before the patient ever gets to the office, right? It's the setup, it's the paperwork in advance, it's the whole patient experience. And I know, speaking from experience with my sister, that a good patient experience means also more compliance with what the provider's telling them. It also creates an atmosphere physiologically in their bodies where they are going to be more receptive to the interventions that you're prescribing or implementing. So it's a whole patient experience. So we wanted to really wrap up this first part of our kind of block of echo videos and recordings and sessions with you all to kind of go back to those basics, navigating that clinical uncertainty, medical documentation, effective tools for communication with your patient visits, and then really bringing it back to the fundamentals of improving those patient outcomes. So next month, Jennifer Bell will be breaking down a very practical approach to complex patient cases. And this will really tap into that kind of recipe for how to go through the, differential and how to decide, which things to go after and manage, when to pivot, and kind of bring this all full circle, but on a very practical clinical basis. And then we'll start going back into some of the other more specialty focused things like hypermobility, pediatric cases, sleep challenges, and then ending the year with neuroinflammation. So I hope you all enjoyed this session. It was so wonderful to see you. Please take good care until next month.